Hello, 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 everyone. Welcome back. It's day 9, and we are going to focus on group 6. Group 6 has 6 root operations that always involve a device. So, as usual, let's talk about the definition, starting with insertion. Insertion is where you're putting in a non biological device that monitors, assists, performs, or prevents a physiological function but does not take the place of the body part. Replacement, putting in or on biological or synthetic material that physically takes the place and or function of all or a portion of a body part. Then we have supplement. Supplement is putting in or on biological or synthetic material that physically reinforces and or augments the function of a body part or a portion of a body part. And then we have 3 more. Next, we have change. And change is taking out or off a device from a body part and putting back an identical similar device in the same body part without cutting or puncturing the skin and mucous membrane. And then we have removal. Removal, taking out or off a device from a body part. We also have revision, correcting to the extent possible a malfunctioning or displaced device. Let me make sure I did all of them. I'm like, did I talk about replacement? I don't remember talking about replacement. So let me just make sure we got replacement. Oh, yeah, you know what? I actually did replacement. All right, let's jump right into it. Was so many of them, I got distracted. All right, so in our first scenario, we're going to be removing hardware from the right distal humerus. So in this particular case, the patient elbow was prepped and draped in the usual sterile fashion, and a stab wound was made directly over the prominent screws going up into the humerus, both medially and laterally. Dissection was carried down bluntly to the screw head with hemostat, and screw head was delivered through the incision. Both screws were removed without difficulty, and great care was taken to avoid the ulnar nerve, which was located more lateral and was palpable throughout the procedure, well lateral to the incision. And then, of course, they closed the patient up. All right, so what happens next? We're going to go to our coding manual, and we're going to go to the index, and in the index, we're going to go to a root operation of removal. And is this one of those situations where I should have went backwards? But these days, I guess day 9, I can scroll a lot faster than I could on day 1. And as I mentioned, I generally use the physical book, but I am a firm believer if you're learning how to code and you can't get the book, this is a great way to do what you need to do. So, and if you are in a associate's degree program where on your RHIT or RHIA exam, you really won't have a lot of coding, this is a great way to practice coding without the expense. All right, so this was the humerus. So, let me just tell you this. This is removal, and then we have removal of a device. And so we had a device, right? It was in the humerus, humeral shaft to be exact. So, humeral shaft. And I know I could just feel some of you are saying, well, how do we know that it was the humeral shaft? Because it was the distal humerus. It's always those little things that you're like, man, how did you know that? All right. So humeral shaft, it was right. So that's taking me to 0 ppf for the body part, which was the humeral shaft. And this is one of those longer situations. So we have F for the humeral shaft. It was open. What was removed was the internal fixation device, no qualifier, with the final code being 0ppf04Z. All right, let me put my code book back to the top, and I'm going to go back to the scenario. And now we're going to go to our next case. So this next patient came in for an insertion of a Powerport for chemotherapy. I said this before, but I'm going to say it again. If you don't know what you are coding, you can make an error in coding just based off the fact that you don't know what is actually taking place. And so in this particular case, I want you to pay close attention. The patient was given IV sedation, neck, chest, all of that was prepped, draped. Anesthesia was administered. A tunneled catheter was inserted into the left cephalic vein, ending up in the superior vena cava. So I want you to remember that there was a catheter put in the superior vena cava. The ties were secured. The catheter was cut to length, locked on the portacath infusion device, and the device placed in a pocket in the subcutaneous tissue in the chest region where it was secured in place with chromic sutures. Irrigation was done, they closed the patient up. So first things first, I want you to know, with this particular procedure, there's two things we are going to code. We're going to code that catheter, which went into the superior vena cava, and then we're going to code that portacath infusion device, which was in the subcutaneous tissue in the chest region. So the first thing we're going to do is pick up that vena cava procedure. So back to the index. And insertion of a device. And I'm going to go backwards. Sometimes I go backwards. That's because it breaks it up. So that's introduction of a device. We may see that before it's over. I can't remember now at this point. I'm just taking it one day at a time. Maybe I should have went the other way. One thing I like about coding is that you have the opportunity just to continue to grow and grow and grow. So it was in the vein. So the vein starts here, and we are in the insertion of the device. So which vein? Oh, vena cava has its own business. All right, I forgot that. So vena cava, it was the superior vena cava, 0 to H. And while we're over here, let's get the table for the subcutaneous chest wall. So that was subcutaneous tissue is what they said in the scenario. All right, subcutaneous tissue, and then chest takes us to table 0JH, and then the 6 for the chest. So I'm going to, well, since I'm here, let me just grab this code. We're already over here. 0JH. 6, right? And where's 6? Another part of the table. Remember we talked about that? All right. This was open, and this was a vascular access device tunneled. Remember that part? So that's an X and no qualifier. Final code for the insertion of the device into the chest wall, 0JH60XZ. And then this gives us an opportunity to build from the table. So 0, 2, H. And then from there, it was the superior vena cava, which we were told previously that was a V. This was open. Now, let me just think about this. Let's go back to this scenario. Because a tunnel catheter was inserted into the cephalic vein, ending up in the superior vena cava. And I want to know what you guys think. Is this a situation where this is percutaneous endoscopic, or not endoscopic, but percutaneous? What do you guys think? Or is it open? So a tunneled catheter. And I think that one of the things I would, and I should say this, real life, the scenarios are a little longer. But after infiltrating with local anesthetic, a tunneled catheter was inserted. Now, I've had learners before say to me, well, they felt like this was open. Others said that it was percutaneous. And so I feel like with how the scenario is worded, that it's percutaneous endoscopic. But I'm not really seeing open. And this is a situation where I would need to get a picture of the procedure being performed because it can be either case. So, since it was a tunneled catheter, and who knows what a tunneled catheter is? That's one thing that I like to stop and do is really understand what it is that our patient is having, right? Just really to get a better understanding. And I know what it is, right? It's this tube. It's like a little flexible tube that goes into that vein in our chest. I know that there's a difference between a tunnel catheter and a non-tunnel catheter, right? So I know that there are these differences, but I really feel like in this particular case that I would go with percutaneous, because usually but it also could be open. And let me explain why. Because generally, before inserting the tunnel catheter, the doctor will make an incision um, at the insertion site, which, in our case was the chest, and then using a tunneling device to form that tunnel. But in our scenario, I just feel like um, I'm missing that incision. Okay. So this is where we have a relationship with our clinical staff. We can do a query to the provider. More than likely, we would have much more, a little bit more information in the medical record to make that determination. So for now, I'm going to go with percutaneous. So that's a 3. And then our device is an infusion device and no qualifier. So 0 to HV 3 3Z. And again, I feel like the documentation is lacking the information that we need. All right. I told you that the weekend was going to be a little longer, and I did not lie about that, right? All right. So the next patient was admitted for a hip replacement surgery to treat post-traumatic osteoarthritis that involved both hips. They did a successful left hip replacement, which was performed using ceramic on ceramic hip replacement bearing surface prosthesis, and it was cemented in place. All right, so we're going to go back to our code manual. We're going to go to the root operation of replacement. I think I'm going to go backwards again. And just to refresh, it was the left hip. It was cemented, had that ceramic. So I want to make sure we get all of that in there. There's another time when I should have started at the beginning. Oh, well, I'm here now. I do hope that all of you have a great rest of the year. After our last day, I am going to be offline until next year. Spend some much needed time with my family, and just kind of, reflect on the year, thankful for what I've been able to do. And really start to think about in more detail the things that I want to do for 2024. Okay. I'm like, this replacement is long. Hip. All right. And it was the left hip. We don't know about this other stuff here. Femoral surface, acetabular surface. They didn't mention all that. So 0SRB for the left hip. It was definitely open. And so here's B here, was open. And remember, they said the ceramic. So this is a synthetic substitute ceramic, and it was cemented. Final code 0SRB039. All right, I'm going to bring this back to the top. Now for this next scenario, the patient had a chest tube, and the chest tube was replaced. I really had a difficult time finding a scenario like this in my references. So, funny thing, I had ChatGPT create this scenario. I told ChatGPT what I wanted, and it gave me the scenario. It didn't give me the code, but it gave me the scenario. So, this is a change of a chest tube. So, we are going to go back to the code manual, index, change, and I'm not going to go backwards. I'm just going to go forward this time. Change of a device in the chest wall, 0W2, the fourth character of 8 for the chest wall. This is an external procedure, and this was a drainage device, no qualifier. Final code 0W2 8X0Z. And I told you guys this was going to be longer. We're almost done. Hey, and I see I left my notes there. I put change at the top. All right. Our next patient was treated 7 weeks ago at a community hospital, and is now admitted for a surgical repair of an atrial defect resulting from a recent infarction. And following thoracotomy, the defect was repaired with a non-autologous tissue graft. And the patient was on cardiopulmonary bypass. We actually coded cardiopulmonary bypass before. And in this particular case, they say extracorporeal circulation, continuous cardiac output was used. So we have two procedures to code. We have the non-autologous tissue graft, which is a root operation of supplement. So let's get to the letter S's. Well, actually, I'm going to go backwards because I feel like I'll get there faster this way. Okay, supplement and supplement where it was an atrial defect. Remember that? And let me go back to the scenario because I actually kind of forgot what I was looking at. So atrial defect resulting from an infarction. And so they did a non-autologous tissue graft. Okay, so now I know. There's another one that's kind of long. My hot tea got cold looking at all these index entries. Okay, I feel like I missed where I should have been going. So let me just go a little slower. Arm, artery. I know I should be in, now I'm just going to tell you, I know I'm supposed to be in table 02U. I'm just going to go over there because, yeah, I know it's a heart and great vessel. So let me see. Yeah. Oh, you know what? I don't know what I was looking up wrong, but here is the atrial septum here. So let me go back because I feel like I missed something in the index. And just in case you're wondering, no, I do not know all the tables. In fact, I just remember that table from the other day. I don't do cardiology, not my friend. I just remember that table from the other day because I just kind of got a little photographic memory. So you see that's atrium there, but that's not the we saw that it was a 5. So let's see if it's under septum. Uh-oh, there we go. Septum, atrial, 02U. And then we already said it was a 5. Our procedure was open. They did they said non-autologous, so non-autologous tissue substitute, and then no qualifier. So 02U50KZ. All right. We also had I'm going to go to the tables for this. We had that coronary pulmonary bypass. That one's kind of an easy option. Now, we're not going to do anything outside of medical and surgical. We're only coding these when we had a cardiac case. But notice how you have assistance, performance, and restoration. Our patient had the performance. So that took us to 5A1, 2, 2 for cardiac, 2 for continuous. Five A1, 2. I got lost for a minute. And then there was the output, and then no qualifier. So 5A1, 2, 2, 1Z. And I'll just go, and you know what? I just realized I didn't have the book up. But at least you had the scenario up, and you could hear me talk about what I was doing. All right, our very last case for today. This patient came in for revision of the hip arthroplasty. They had a hip replacement 5 weeks ago for osteoarthritis. The prosthesis worked well until the previous week. Then she heard a pop. So they did an x-ray. They showed a displacement of the left acetabular cup, which continued to mitigate proximately despite bed rust. So the left acetabular component of the prosthesis was moved back to put it back into the correct location. So we are going to code this and get up out of here for today. So we are going to the root operation of revision. All right, that's one of those times I should have went backwards, huh? All right, we got to hurry up so we can be done out of here in less than 30 minutes. I got 1 minute left. Oh no. All right, we'll go over just a tad bit. Good thing is these are online and you can refer to them. Tell your friends who want some practice with PCS coding as well. Yeah, definitely one of those times I should have went backwards. We're almost there. And my husband is waiting on me to leave the house. He's like, "What are you doing? Are the 12 days over?" Almost. All right, revision of a device. And now I forgot where the device was at. Oh my. It was in the hip. All right. Okay. So it was the hip joint. Zero SW, and it was B because it was the left side. And okay, so where's our B? Okay. This was open. It was a synthetic substitute and no qualifier. 0SWB 0JZ. Now, also for this scenario, the patient was transfused with 2 units of packed red blood cells. So we can also code that. And in the interest of time, I'm going to go straight to the table, which is 302, administration, circulatory, transfusion, and 3 for peripheral vein, 3 for percutaneous, and it was red blood cells, and it was non-autologous because I don't believe. Let me just go back to the scenario. Yeah, it didn't say that the patient gave their own blood. Okay. All right, guys. Monday morning will be extremely short because we are only doing 2 root operations that involve examination only. All right, guys. Thank you so much, and I'll see you for day 10.